In this introductory presentation, which is also the longest presentation of the course, I'll try to cover everything. So I will give you a brief introduction, however somewhat superficial, to all of the core concepts that I will then later on elaborate in the individual presentations. And I will of course also introduce to you the field of pharmacoepidemiology. So pharmacoepidemiology as a specific discipline is of course something to do with medication in the population level setting, as is all epidemiology. A wonderful framing of epidemiology is provided here without any attempt at actually framing epidemiology from the Arthur Conan Doyle Sherlock Holmes in The Sign of the Four, stating that while an individual man is an insoluble puzzle, in the aggregate he becomes a mathematical certainty. And this is exactly what we are trying to do in epidemiology. We are not really trying to foretell what will happen to any one individual, but we are able to, with quite the precision, to predict what will happen to larger groups of people on average. Pharmacoepidemiology is formally defined as the study of use and effects of medications on a population, basis at least in the Stromkimmel and Hennessy classical textbook on pharmacoepidemiology. And I think it's quite important to emphasize that this duality in the definition, which is sometimes overlooked, pharmacoepidemiology is the study of the use, including use patterns and thus drug utilization, and the effects of the use, which is the more typically included cohort studies or case control studies, etc. So I think there's a duality. It's both the use patterns and drug utilization and the outcome studies. As mentioned, this is an introductory talk. I'll try to cover everything in some level of detail, and you'll hear me repeat this in much greater detail in subsequent talks, but reusing some of the same pointers and some of the same figures, so that it is easier for you to remember and recognize the examples that I'm giving. This is based on almost a decade of teaching this material to master students here at the University of Southern Denmark, and I've found it works quite well. So, in the introductory talk, I'll try to address measures of frequency and association, study designs, and bias mechanisms. Frequency and association, that'll cover incidence and incidence rate, or prevalences, or cumulative incidences, risks, odds, and how we measure associations based on these basic frequency and association measures. The study designs, I'll comment on the cohort design, the case control design. I will comment on drug utilization studies, and I will also give a brief primer to self-controlled designs. And in terms of bias, we will both touch upon the bias overall as a concept and a pitfall in pharmacoepidemiology, and of course dedicate a bit of time specifically to confounding, which is the more tricky one, or at least the more common one that we encounter in almost all studies. So, starting off with measures of frequency and association. The core metric or the core measure is the incidence. Incidence is the number of new cases of some sort of disease or some occurrence. This could, for instance, be the fact that there are 10 incident cases of AMI, acute myocardial infarction, in Denmark each day. This is a measure of the number of new cases. Typically, we don't talk about the incidence, we measure it, but we translate it into an incidence rate. This is the incidence, the one I just presented, per person time. So, for instance, we could take the number of new cases and divide with the total number of observation or person time that has given rise to these cases. For instance, I could say that the incidence rate of upper gastrointestinal bleeding is 50 per 100,000 person years. So for each 100,000 person years, I would see an incidence of 50. What is a person year? Well, a person year is a metric of observation. So this is not necessarily one person followed for a year, although it could be. It could also be 2 individuals followed for 6 months, or 3 followed for 4 months, or 10 followed for 1 month, and 60 persons followed for 1 day. It is simply a measure of the total amount of observation we are doing. It could also be framed as person months or person days or person decades, but typically we use this person years to denote the amount of observation. So an incidence rate would be a matter of measuring or following some individuals over time and measure the two outcomes needed for this sort of brief, simple calculation. We need to know how much follow-up is happening, that is the amount of person time. Here I've noted the number of person years, corresponding of course to the length of the individual line. And as you can see from the figure, there's one case. So across 24 person years, I see one case, which upon division corresponds to 0.04 per person year, or approximately 42 per 1,000 person years. This is an incidence rate. Then we've got the prevalence. This is the number of cases, and thus not the number of new cases as the incidence, it's just the number of total cases. I could, for instance, say that there are 1,100 people living with myasthenia in Denmark, which would correspond to a prevalence of 1,100 Danes. Just as the incidence rate, we rarely talk about the incidence in itself, but we typically use the incidence rate, and similar for prevalences, we rarely talk about prevalence, but rather the prevalence proportion. So this is the proportion of a population that is at any given time have this disease that we want to measure, or have this characteristic that we are interested in. So here it's the number of people with the disease or characteristic divided by the total size of the population. So sticking to the myasthenia example, I have a prevalence proportion of about 1.8 per 10,000, since 1,100 divided by 6 million corresponds to this number. It could also be other characteristics. For instance, it could be the prevalence proportion of use of a drug within a population, here 50% among those that had a previous MI. So it's not necessarily the total population, it could simply be a population of people with a specific disease, and within that population, what is the prevalence proportion of some characteristic. Sometimes you will see prevalence proportion simply be referred to as prevalence, because it is the more common metric, when prevalence proportion is actually what is meant. So in this figure, sticking to the MI population example with beta blockers, for this particular point in time, denoted with the dotted line, half of the population of 4 people are current users of beta blockers, and thus we have a prevalence proportion of 50%. And as you can also see from the figure, if I had measured it at some other time, it might have been 2 out of 5 or 3 out of 4. So it's quite important to be specific, when did I measure this? And this is a prevalence proportion, a point prevalence, because it's measured at a specific time point. Then we've got the cumulative incidence proportion, or CIP. This is the proportion of individuals that within a given period of time experience a new outcome. So not prevalence, but incident outcomes, as denoted by the incidence. So the CIP is what we typically would refer to as risk. So it could, and this is measured as the number of new outcomes out until some point in time, divided by the number of people at risk at time 0. So for instance, among all those admitted to a hospital with an MI, there is a 10% 30-day mortality risk, or cumulative incidence proportion. That is, 10% will see an outcome here, death, within 30 days from having their MI. This is a cumulative incidence proportion. So going back to the same type of figure as before, we have here 7 people. We'll follow them over time. Within 8 years, one of them will have an event, which denotes a CIP of 1 divided by 7. The odds is another type of measure, and this is for various reasons a very interesting measure, but mainly these reasons pertain to mathematical properties. There is no, to my knowledge, sort of real argument as to why this is particularly useful outside these mathematical properties, which I won't go into. But in short, this is instead of the outcome divided with the total population, this is the likelihood of having the outcome divided by with the likelihood of not having the outcome. So for instance, getting back to our MI example from before, the odds of dying within 30 days after having an MI is 1.11, because it's not the number of outcomes divided with the total population as before, but it's the number of outcomes divided by the number of individuals not having the outcome. So instead of 10 over 100, it's 10 over 100 minus the 10 we had. So in the other example I used, we followed these 7 people and one of them had an outcome. So instead of the cumulative incidence proportion of 1 divided by 7, this is an odds of 1 divided by 6. So having these basic metrics or ways of measuring frequency or occurrences, we would like to create associations, or typically at least we would. So association or measures of associations are relative measures for some sort of frequency of an outcome. This could in pharmacoepidemiology be a matter of comparing drug users to non-users or users of another drug. So we could translate the incidence rate into an incidence rate ratio. That is, if we divide an incidence rate in one group with an incidence rate in another group, we will obtain this relative measure of frequency that comes from an incidence rate ratio. All the KIP could then, or 2 KIPs could translate into a relative risk, the odds into odds ratio, etc. So generally speaking, the larger the relative risk or incidence rate ratio of odds ratio, the stronger the relative association between the exposure and the outcome is. In pharmacoepi, typically use of a given drug and some sort of health outcome. This could look like this. So let's say this is a relative risk, so 2 KIPs divided by another. And one group apparently had a slightly higher risk, and thus the relative risk comes down to 1.3 with a confidence interval. So the interpretation here would be that there is a 30% relative increase in the risk of this outcome with the exposure that we are looking at. The 95% confidence interval, of course, denotes that this is not statistically significant, since 1.0 is part of the interval. However, I want to make a note that there is a common misinterpretation on the confidence interval as this denoting an interval within which any value is equally likely. And this is not the case, in fact. The confidence interval is not a uniform distribution and anything is equally likely within this interval. And to be honest, there can be bias mechanisms, there can be other reasons why we have seen deviating results, and thus we can also consider results outside the confidence interval if we know, for instance, a bias mechanism will affect our study in this or that direction. So just remember that these sort of confidence intervals, this is a distribution such as this, and the 1.3 estimate we just saw is the more likely value compared to, for instance, 0.8 or 1. Or the other sort of out boundary of our confidence interval. This is one that agrees the most with what we've observed, but of course we need to interpret the full confidence interval. So this is your first pause geek, and thus I'll remind you that this is a suggestion for you to take a small break, pause the video, and get up from your chair for a little while, and then resume this introductory lesson. For the subsequent pause geeks, I'll simply stare at you for 5 seconds to give you a chance to pause the video, get up, get back, and start me again. Moving on to study designs. The classical observational and pharmacoepidemiology type of study is the cohort study. Here I would follow a group of users of a given drug and a group of non-users or users of another drug, and I'll follow them over time to compare them regarding any given outcome, using some of the measures of frequency I just described. An alternative study design, also quite commonly used, is the case-controlled study design, in which I will take a group of individuals with a given outcome and I will compare their use of drug to the use of the same drug within a group of individuals not having the outcome, typically denoted as controls. So in the cohort design, I'll follow people over time, and some will experience the outcome, here denoted with the red dots, and some will be censored or removed from the study due to, for instance, migration or death, here denoted with green dots. And just as I described before with frequency, this is a matter of now tallying the amount of person time and the amount of events so that we can come up with measures of frequency and ultimately measures of association. So for instance here, I have 108 person years and I have 3 outcomes which I can translate into an incidence rate of 28 per 1,000. And this might be the example from the exposed group, and I'll do the same thing in the unexposed group or users of another drug as said. And from this I can translate the 2 incidence rates into an incidence rate ratio, that is a measure of association here of 1.4. That is, the rate of the outcome in question is 40% more likely in the exposed group than the unexposed group. So going back to the cohort design, the thinking of a cohort design is we follow everyone to measure the amount of person time and the outcomes. The alternative design would be the case control design. And here I have graphically tried to sort of illustrate the fact that there is really no difference in the thinking of the two, in that we are starting with the same population. However, we are only looking now at the outcomes, or at least to begin with, only looking at the outcomes. Here we then look at their drug use, for instance, in a small window leading up to the outcome event, whether they used a given drug or not, and we'll sample some additional person time from this underlying cohort of everyone, that is among people with not having the outcome at the time of sampling, and we'll look at their drug use as well. So this is a comparison of the exposure patterns among those getting the outcome to the exposure patterns in a randomly selected group of people not having the outcome in the underlying cohort study, so to say. So let's go back to the cohort study. Assume we have 10,000 girls, they are aged 20 to 25, they're all using oral contraceptives, and we follow them for 3 years. Among this group of this cohort, we see 200 events of deep vein thrombosis. We also follow a cohort of 20,000 girls not using oral contraceptives, but they are of similar age and they have a similar follow-up. In this cohort, we will see 100 incident cases. The question is then, of course, what is the incidence rate ratio? Here you can pause for a little while to think about it if you'd like. So first we need to identify the total number of follow-up, and we have 10,000 girls that are followed for 3 years. So we have 30,000 person years of follow-up. We have 200 cases, and we'll divide those with the 30,000. In the other cohort, we had 100 cases and 20,000. 20,000 followed for 3 years equals 60,000. So we have 100 events among 60,000 person years. And dividing those two, 200 per 30 and 100 per 60, will yield us an incidence rate ratio of 4. The corresponding case control study would be a matter of identifying the girls with deep vein thrombosis and asking them about their use of oral contraceptives. Here, 80% had used oral contraceptives. We'll then identify other girls from the same underlying cohort, and we will sample them at a random time and only include those that did not have a deep vein thrombosis at the time of sampling, and we'll ask them about their use of oral contraceptives. And from these metrics, that is the total number of cases and the use of the drug, we would be able to devise this 2 times 2 table of having the outcome yes, no, having the exposure yes, no, and from that we can get an odds ratio which should in most cases be more or less identical to the cohort study outcome of an incidence rate ratio. So this is just a brief intro to these 2 different designs, and I typically here quote Ken Rothman that if you are doing it right and you are controlling the right way of sampling your controls, etc., you can basically get anything from the case control study that you could from the corresponding cohort study. Finally, I'd like to touch upon the self-controlled designs. This is not part of the full course, but hopefully I will include a video in the future with a little more details on these very interesting and also increasingly popular designs in pharmacoepidemiology. As a classical example, I'll use the case crossover design. And here you can see a set of individuals included in such a study. Here I'm looking at an outcome denoted with the little blood drop, and there are some triangles. This is where I measure exposure, and there are prescriptions denoted with the small rx, denoting exposed periods of time. So just looking at the top individual, here we see the outcome event denoted by the blood is not an exposed situation, or there is no drug use at the time of outcome, and we'll also ask about this individual's exposure pattern back in time. Here we use 3 different windows, and in one of these there was an exposed period, but 2 of them were unexposed. This is somewhat similar to the case control study design, just the fact that this individual serves as his own control. So that, and this gives quite some interesting properties. For instance, that anything that is stable over time, this could be genetics or any metrics of health that is stable over time. But of course also, when this is in a narrow window, other characteristics such as age, which is of course not completely stable over time, but stable within the time window that we're looking at, and so is typically BMI and smoking patterns, etc., will give this individual a very comparable comparison to himself within these 4 windows. And we do this across a bunch of individuals, compare their drug use at the time of outcome to their previous drug use. This is the core idea of a self-controlled design. There are also other designs within the family of self-controlled designs. There's the symmetry design, which we simply investigate the order of exposure and outcome. If there is no association between the exposure and the outcome, we would typically expect to see an equal distribution of people experience one before the other and the opposite pattern. But of course, if the exposure causes the outcome, we would expect to see more exposure outcome patterns than we see outcome exposure patterns. This is a very simple design that also has this inherent property of controlling for confounders that are stable over time, since we are only doing the study within the individuals with the outcomes and comparing them to themselves. If you'd like a quick primer to self-controlled designs in pharmacoepidemiology, I have written a paper together with Jesper Hallers, which was published in Journal of Internal Medicine. Then there's the discipline of drug utilization. And this is very much a study in its own right, or discipline in its own right, and some might even argue this is also going beyond what is typically considered pharmacoepidemiology, which I'll get back to. But really there's so much you can do within drug utilization. For instance, investigating incidence rates and prevalence proportions of drug use, illustrated by the metrics I used just before. But we can also look at what are the single substances used here, the distribution of single SSRI products, drug survival, that is the adherence or compliance with treatment, how long are you treated after drug initiation, co-medication. You can estimate distribution of daily doses or what type of prescriber issues a given drug. That might be regional differences, or it could even be skewness in use as a marker of abuse potential. So there's all other metrics of use. So there are very many different things you can do in drug utilization, and generally speaking, you should always do some of this to understand the exposure patterns in your cohort, also if you're not doing a drug utilization study, but a drug outcome study. Finally, let's get to bias mechanisms. As an overall intro, I'd like to emphasize that we have random variation and we have systematic error. And when I'm talking about biases, it's the latter that I'm talking about. And there might be different ways that we can see a systematic error in our study. And typically we can reduce this to selection bias, information bias, and confounding. I have heard it argued, for instance by Toby Gerhardt, that you can reasonably sort of put any bias mechanism into one of these three bins. When we are consulting our statistician colleagues, they are very adept at handling random variation and describing and presenting that, and also handling confounding, whereas as an epidemiologist, you're typically an expert in not only the confounding aspect, but also other mechanisms of bias that stems from sampling or data validity. So this is sort of the distribution of responsibility between these two, let's say, typical collaborators in an epidemiological study. Confounding is the core type of bias that most often gives us a problem. This denotes lack of comparability when we are comparing two groups that cannot, for one reason or another, be compared. It refers to the mixing of effects, because if we are comparing incomparable people, we might think that this is due to the exposure that we have used to divide them into two groups, but in fact they are not comparable for other reasons, be it, for instance, age, and we are thus mixing the effect of the difference in age with the effect of the exposure, if we are not controlling for it. So, in a more formal way, the confounding is an error or bias caused by lack of comparability between users and non-users of a drug, or users of one drug and users of another drug. So a classical example would have a sort of a triangle like this. If I'm interested in looking at whether use of vitamins affect your risk of having an MI, there will likely be a confounder in the fact that those using vitamins tend to exercise more, and exercise reduces your risk of MI. Thus, if I'm only looking at vitamin use, I will see a protective effect, but it's actually a confounded effect, a mixing of the exercise and vitamins effect into one. Formally, I will require a confounder to be associated to the outcome. So it really doesn't matter if exercise is randomly distributed among users and non-users of vitamins. Then there is no confounding effect. But in this case, exercise is associated to the exposure, and this might be positively or negatively associated, so it's either more common or less common. It doesn't really matter here, just a matter of whether it is different between users and non-users. And exercise is, of course, associated to vitamin use in terms of people wanting to protect their health and do something special to that end. Also, a confounder needs to be associated with the outcome in question. And here, exercise, of course, affects your risk of having an MI. And this also means that if something is suspected of being a confounder, and it's associated with the exposure, but it's not really a risk factor or any sort of influence on the outcome in question, it's not really a confounder. Finally, it needs not to be part of the causal chain, that is, it should not be caused by the exposure. Consider an example of having the exposure as statin use, and then after statin initiation measuring the patient's LDL level and adjusting for that. That would not work, because this is actually something that is affected directly by the exposure and part of the causal chain from exposure to the reduced risk of cardiovascular endpoints. That is the benefit of using statins or cholesterol lowering medication. And in this case, this is not a confounder. Of the three, what is typically forgotten is the second metric, in that it's whether something is associated to the exposure. So people tend to talk about confounders as the metrics that are known risk factors or protective factors in terms of experiencing the outcome. However, we tend to forget to discuss whether this is distributed differently between users and non-users of the drug. And really, if you have even a very strong risk factor, if there is no reason to suspect this strong and potentially unmeasured risk factor to be different between users and non-users, it's not really a confounder. Of course, if you have the data, you would adjust for it. But again, we tend to forget that it needs to both be a risk factor, but also unevenly distributed between the two groups we are comparing. A few exercises, and I'll pause briefly after each for you to potentially pause the video and think before I'm providing the answer. In a given comparison, I find that users of bras have higher risk of breast cancer compared to non-users of bras. Here the confounder is somewhat obviously sex, in that users of bras tend to be women more commonly than non-users, and women have a higher lifetime risk of breast cancer compared to men, although men can also get or evolve breast cancer. So in such a comparison, it would seem like I'm mixing the effect of wearing a bra with the effect of being of female sex. Second example, persons with a high alcohol consumption also have an increased risk of lung cancer. Here the confounder is also quite obvious, but not as obvious as before. It is a matter of smoking. People with a high alcohol consumption on average smoke more than people with no alcohol consumption, and thus in a comparison of alcohol versus non-alcohol, we are actually mixing that with also the effect of smoking versus not smoking, and thus we see an increased risk of lung cancer, which isn't really caused by the alcohol in itself, but rather confounded by smoking patterns. The third example, users of weight loss products have a higher risk of hip fractures compared to non-users of the same age. So here I take age out of the equation by saying that the comparison we have already taken care of age. However, users of weight loss products have a higher risk of hip fractures. Here we might have several confounders at play. One confounder might be that upon initiating weight loss products, you are typically also increasing your physical activity, and physical activity is a risk factor for hip fractures. Another potential confounder that will drive the association in the same direction could be that those using weight loss products have a less healthy lifestyle and might then have a less ideal bone health compared to those with not using weight loss products. This might also increase the risk or make a spurious association via confounding. There could also be the opposite pattern, that people with using weight loss products generally on average have higher BMIs than non-users, and a higher BMI gives a certain protection against hip fractures, basically due to the padding it gives, and thus this might actually drive the association down so that it seems that weight loss products protects against hip fractures. And thus I wanted to illustrate that there are typically more ways than one that a given characteristic or association can be confounded. Final example, use of low-dose aspirin, ASA, or acetylsalicylic acid, have a higher risk of MI compared to non-users of the same age. This is a specific situation that is typically referred as to confounding by indication. We are using this drug specifically to treat or prevent rather myocardial infarctions. And in this context, you should expect that users of the drug have a lower risk because that's what we've seen in randomized controlled trials. However, in the observational setting, we will of course give this drug to those at particular risk. And if we're doing the simple comparison of use versus non-use, we will see that use drives an increased risk, which is of course because we're giving these drugs to those at higher risk, and even with the drug, their risk is still higher than the risk among those with no risk factors. This is a particular version of confounding called confounding by indication. Other types of biases, we have already covered confounding, but we should also mention selection bias and information bias or misclassification bias. And in the subsequent talk, I'll also touch upon reverse causation bias and immortal time bias. So selection bias is bias coming from outside the material. This could be due to selective inclusion of individuals with particular characteristics, which is related to either exposure or outcome. So if something is associated to your likelihood of getting into the study, which is also to do with the reason why you have the outcome or potentially the exposure, we can see bias in our findings coming from outside the material due to selection bias. Information bias, on the other hand, is bias from within the material due to incorrect information. So I might have a representative sample of the population in question, but I might have incorrect information. Something isn't measured right, either in terms of exposure or outcome. And information bias, we usually divide into two sort of buckets, be it differentiated and non-differentiated. The differentiated information bias, that's the case when this lack of information or imprecise information is unevenly distributed across the exposure groups. So one of the two groups I'm following, for instance, will have a different level of accuracy in their outcome coding or exposure coding. And when I have differentiated across these exposure groups, there is really no way of foreseeing how this might affect my study. And so the bias mechanism can go in either direction. Whereas in the non-differentiated, where there is no difference in the exposed or unexposed in terms of this lack of accuracy in my data material, there is, on the other hand, really, again, I cannot guarantee what direction the bias mechanism is in, but in most cases, this will give a bias towards the null, because it will sort of make the two groups more comparable. Regardless of what the exposure gives, the sort of incorrect information will blur my comparison a little bit, and typically this will reduce your associations to a less of a difference between groups, so a bias towards the null. This was the full introduction to the everything all at once. This is the longest of all the presentations in this course, covering everything in a very basic introductory way, and now you are equipped to take a deep dive into the individual topics.